Okay, everybody. I think I've waited long enough. I've gone a little over, and I want to be respectful of the people who are tuning in online as well to see us today. First of all, let me tell you who I am. My name is Brian Dowd. I'm the Deputy Executive Director over Policy, Operations, and Compliance at the Department of Community Health, which is really just a fancy way of saying I'm mainly the policy guy, the guy who does a lot of the policies around member eligibility and also around what you receive once you're on Medicaid, which is more medical policy. I also used to be previously the waiver guy, the home and community-based waiver guy. That wasn't my title, but that's what I used to tell people I was. And so I inherited electronic visit verification like Lynette said back in 2018 in our opening presentation. It was a federal mandate, and we were required to do it, or the state faces a penalty. We actually have to pay a larger portion of state tax dollars for Medicaid if we do not implement EVV. That's one of the reasons why we implemented, honestly, that's the real reason we implemented EVV. But also we saw the opportunity for quality, and we saw the opportunity for fraud, waste, and abuse, looking at fraud, waste, and abuse as well. So today I'm just going to do a brief overview of the EVV program, let you know where we're at. I'm mainly going to focus kind of on some Q&A and some stuff that's still outstanding in the EVV world, but I will give you a little bit of an update. And then I'll leave plenty of time if you all have questions, comments, or concerns so that you can voice them to me. We also have one of my other deputy executive directors in the room, so you have 2 out of the 4 right now. Rebecca Duggar is in the back, and we have Lindsay Mack from NetSmart as well. So we have a full crowd. She's waving as if she is on a parade float currently. So we have a good group of people here. We should be able to answer any comments, concerns, and questions you may have. I'm going to slip through the technical ones and just give you the mission of the Georgia Department of Community Health, which is to provide affordable quality health care through effective planning, purchasing, and oversight. And believe it or not, I've done enough presentations that I now know that off the top of my head. It's only taken 3 years. So what are we going to go over today? We're going to talk about some operations updates. We're going to do some common issues and frequently asked questions. We're going to talk about our phase 2, which is HHCS. We're going to give you a list of our third parties that you may utilize in order to be EVV compliant. We're going to tell you how to contact the call center. Our call center, the conduit EVV call center. We're going to go over that, and then we're going to do a Q&A if you guys have any questions, comments, or concerns. So let's start with an operational update. As Lynette said, we are certified by CMS. And I know you're probably thinking, well, like, who cares, right? And I appreciate that, but it is a big deal for the state to be certified, because what it allows us to do is not be in jeopardy of those penalties to the Medicaid program where we have to pay an enhanced match. So what does it mean to be certified by CMS? CMS has a group of contractors that actually come in, and we spent the better part of a day showing them every single aspect of our EVV system. They dug into the specs of it. They dug into our third-party integration. I mean, as basic as how do providers sign in and out, and how do you clock in and out. They had 100 questions for us about the way our EVV system works. And ongoing, they look at key performance indicators to ensure that we are remaining compliant with EVV. So the federal government looks at things like what is the percentage of claims that are running through EVV versus what is the percentage of claims where providers are billing directly to GAMUS. They look at who is compliant with the EVV system and who is not. We send in metrics on how many manual updates providers are doing. So, and I use this all the time. When I used to work at a record store, records are these things that play. For those of you that are young, they play music. They're made out of vinyl. A long time ago, I used to work at several record stores. Those of you who grew up in the area, I worked at Peaches and Coconuts, Record Town, and Tape World. They were all the same company, but I worked at mainly Peaches and Coconuts. And I was terrible about clocking in and out. I was the worst. So much so that at one point, they wrote me up for it. My store manager was like, hey, you have to clock in and clock out. Quit just coming in and working and leaving and then saying, hey, I was here from 8 to 7. That's why we have a clock in and clock out machine. And I'm having to go in and do a whole bunch of manual updates every week to get you paid. So I had like this letter of reprimand. Seriously, at a record store, I had a letter of reprimand that went into my personnel file at the record store. But then I started clocking in and clocking out. So one of the things that the Centers for Medicare and Medicaid Services and ourselves look at is how many times are providers actually going in and adjusting that record? How many times are they doing it rather than just allowing the system to clock individuals in and out? And that's an example of our key performance indicators. We are doing really good with our key performance indicators. They continue to go up and up and up on a really positive trend. We just sent in another quarterly group of key performance indicators, and almost 90% of the activity that is done in the state for personal support services runs through EVV. There's less than 10% at this point where there are exceptions. They may be old claims that are having to be reprocessed, or something specific where we've granted the authority to bill through GAMUS directly. So CMS is pretty pleased with our key performance indicators at this point. Okay, so let's talk about some common issues and questions that have come out of EVV and that I continue to get as part of EVV. By now, I hope you know that we have implemented rounding rules in the waiver programs. This is actually a national thing that is going on right now that we tackled about a year ago, if not more. But I'm part of the National Electronic Visit Verification. I'm on the board of that association, and every other state I talk to is asking us, how did you deal with rounding? How did you deal with an aide that works an extra minute or an extra 2 minutes where because we used to just round up. If you work 30 extra seconds, we rounded up to a full unit. And one of the things we realized is, well, that was really shortcutting our members in the number of units they get. So what we did is we went with CMS rounding rules that they use for Medicare, and also the rules you might have learned when you were like in the 4th grade. So if it's 8 minutes or more, it's rounded up to a 15-minute unit. If it's less than 8 minutes that the staff work, it's going to be rounded down in a 15-minute unit. Those of you that do the independent care waiver program, are there any of those people in the room? Yes, I see people nodding and some people raising their hand. You may know that personal support services in that program runs on a 30-minute unit. Therefore, if your aide works less than 30 minutes, it's going to round down an extra 30 minutes. More an extra 30 minutes, it will round up to the next whole unit. So just to give you some examples, because I get lots of questions on this, if an aide clocks in at 12:58 and clocks out at 3:12, that's a total of 2 hours and 12 minutes. 12 is more than 8, so they're actually going to be paid for 9 units, right? Because 12 is 8 or more, so they're going to get paid for 9 minutes. But if an aide clocks in at the same time and were to leave at 3:05, now they've only worked 7 minutes. So that's going to round down. It's not going to give you 9 units, it's only going to give you 8 units. So you can manually adjust these if you need to, but I'm going to caution you guys on one thing that I've seen several times and talked to several times with providers. I have had more than a few providers, probably 20 or 30 providers call me. And one of the things you guys are really, really attuned to is you know the number of units you have available for your members in a week or a month or a year. And you're very concerned about running out of those units, which I really appreciate because it shows that you really are thinking about your members all the time. So let's say Brian has 2 hours of personal support services a day. They run between 12 and noon. A lot of you guys are going in and manually adjusting that to 8 units, regardless of however long your aide works. And you really can't do that because you have to we can't do uncompensated care. If your aide was there for a valid period of time and they ended up working 2 hours and 15 minutes, that's a conversation your aide is going to have with the member to say, hey, I'm working an extra 15 minutes here because you needed me to finish doing laundry or help you with bathing or whatever else. But you realize that 15 minutes is going to come off your schedule somewhere else because you have a certain set number of authorized units. But just like we're concerned about your paying too much for somebody, paying when they're not actually delivering service, which was the point of EVV, I've also seen the flip side of EVV, where we're actually shortcutting the staff because we're so concerned about those PA units. So, and I often do this. I go ahead of where I'm supposed to leave, but that's really what I'm talking about right here in billing-related issues. You really need to focus on why those claims denied, what are the PA units, how many units you have, and are your PAs, are your schedule working according to your prior authorization units? The most amount of questions we get now are really not EVV related. We just sent in 20 or 30 research questions to GAMUS around missing PAs, and missing members. The missing PAs and missing members were most frequently PAs that had not yet been authorized, or they were authorized for another agency and they haven't switched over to your agency because the member has switched service providers. The missing members we get a lot are members that are not eligible for waiver Medicaid yet. They're what we call PMAO members, where DFACS has to make them fully Medicaid eligible. Those are folks that are in qualified Medicare beneficiary, QMB, specified low-income Medicare beneficiary, SLIMB, or something that's called qualifying individual 1, QI1. If you get those members, it doesn't mean they're not eligible for the program. It means that the waiver service has to be, the waiver category of eligibility has to be established before that member will come across from the GAMUS system to the EVV system. So please make sure when you say, hey, I've got a missing member, or hey, I've got a missing PA, make sure you've gone into GAMUS and checked and made sure that that member's eligible for waiver Medicaid and that the PA is in the system under your agency. Because the vast majority of concerns we're getting at this point are related to those two issues. Also, you can call the call center. We've had a few folks tell us, hey, something's funky with my phone. Like it's not, I'm clocking in at my member's address and it's showing me, 200 miles away. Well, we can help you with making sure that your phone is calibrated at the call center. You just need to go ahead and call the EVV call center, and all that information is included here, and they can help walk you through that. We talked about missing members and missing PAs. This is, again, I'm terrible with staying with slides. I'm sorry if this is the first presentation you've seen me in, but I never pay attention to the slides. But this is exactly what I talked about with QMB, SLIMB, and QI1. Make sure your members are not just in those aid categories before calling us. Now, you may need to get with case management and say, hey, where is this person in the DFACS Medicaid process? Have they submitted their application? Is it almost approved? What are they missing in verification to get them approved? Another thing that we are strongly trying to let folks know about is the claim submission deadline. So it has moved up. So it used to be Friday at noon, but submitting through EVV needs to be done Thursday by midnight if you want those payments to appear on next week's remittance advice. We are a strange state agency in that we pay weekly. We pay our providers weekly. I know many states that don't do that. There's many states where they are weeks behind in what you bill, or even they only pay providers monthly. But in Georgia, we do pay you weekly, and we pay for the week submission pretty much in real time, which other states don't do either. They have payment lags. So, but just make sure anything before Thursday at midnight will be on the end of the week. If you're billing on Friday, it will be in the next week. Rate increases. We've already completed the mass adjustment for EDWP and ICWP, so they're no longer in process, with the exception of one thing that I want to make sure you guys know. Within the CCSP program, if you do skilled nursing, there were a group of codes that did not get the 10% rate increase mass adjustment. We are doing that mass adjustment right now, and it will show up mid-month. Mid to end of this month, it will show up on your remittance advice. So this is just in CCSP. That's the only program where we didn't do the mass adjustment, and it is just for skilled nursing codes. We are in the process right now of doing the rate adjustment for now and comp as well for the first 5% increase. That should be done by mid-December. I also want to make sure that you guys are taking advantage of what GAMUS or Gainwell can do for you. You know the opening session when Cheryl, which is the lady who from Gainwell, was talking about, and she was introducing all of those people, right? And people were standing up and people were like, yay. Okay, those are your field program specialists. They're here to help you. We as a state pay them a lot of money to help you. So it's not something that is wrong. It's something that you guys should really be taking advantage of. A lot of times you guys will call me and I'll say, well, did you check your remittance advice? And I will hear, well, what's a remittance advice? And I'll be like, ooh, okay, well, I need somebody to show you what a remittance advice is for a couple reasons. One, it's your accounting for every single claim you do. So it shows you for every single person you're trying to bill for, whether you got paid, didn't get paid, and if you didn't get paid, why you didn't get paid. It also posts all of our banner messages to you guys. So if we're trying to communicate to you all, we frequently do that via banner message. So we'll put a message on that remittance advice and we'll run it for 4, 8, 6 weeks so you guys know of that information. So if you're not looking at your remittance advice, then we really need you to start accounting through your remittance advice. They can also help with, why did my claims pay or not pay? They can show you how to void claims. They can show you how to adjust claims. Maybe you initially billed a claim for 8 units and now you got to go back and adjust it to 10 units. They can show you how to do that. They can show you how to look at your service units and prior authorizations you've been approved for. If you contact me, I a lot of times will just contact Sharona or Gainwell and say, hey, if it's a question I can answer and it's EVV related, I usually just answer it. But if it's related to one of these things, I usually ask Sharona to have a field program specialist sit with you to provide one-on-one training about what your issues are. Because that, to me, is the most valuable thing you can do, is understand how the billing system actually works. And you can request them yourselves. That's why I was giving you this link at the bottom. And guys, we'll post all these. at, I think, never mind, it's already posted on the website. It takes a village to do my presentations if you've never been in one before. Thank you. So let's talk a little bit about the home health care implementation. So as you may know, we're pretty much done with phase one, personal support services. But there's another requirement within the Cures Act, which mandates EVV, which is to also implement for home health. Now, it is just the home health benefit in the state plan. That is all it relates to. So if you are an adult day health provider and you do home health out of your adult day health, we will not be implementing it for that. If you are a children's intervention services provider and you do OTPT speech, we are not implementing it for that. It is only the home health benefit because that is all that is required by CMS. The initial deadline to have that up and running is January 1st, 2023, which is less than 60 days from now. So we won't be doing that. We have put in a good faith exemption request to the Centers for Medicare and Medicaid Services, requesting another year so we can implement home health in phase two by January 1st, 2024. They sent back 2 questions for us. We haven't answered those 2 questions yet, but they're really, really simple, easy questions. We've just got to find the original Word document and send it back to them, which is kind of a little bit of our problem. But once we do that, we are very, very confident that CMS is going to allow us an extra year, and we will be implementing home health as of January 1st, 2024. We will do HHCS, which is home health care services. Just like we did EVV, we'll have a registration period, a training period, a soft launch, and then a mandatory go-live date. These will also involve our care management organizations because they also have a home health benefit. In the first phase with home and community-based waivers, as Lynette talks about, that's all fee-for-service. So you don't work in the care management organization space, but the care management organizations do work in the home health space. All right, very quickly, I wanted to give you the current list. I'm pretty sure this is close to the current list. It may not be the current list, but it's pretty much the current list of vendors that are compliant with the 21st Century Cures Act in the state of Georgia. I can confidently tell you, after being on the EVV, NEVA, the National EVV Board, Georgia has way more options than any other state in the nation. There are many, many states that said, you don't get to pick anybody but the state who the state brokers with. You must use the state-sponsored system. We didn't do that. We allowed you to pick a third party that implemented with us or use the free state-sponsored system. In states that have open models, nobody has near this many options. The most I've heard in another state is 12. And we have many, many options for you to use. I will also remind you, though, the free state option is always available for you. And I also want to remind you that I will not manage these folks for you. I care very deeply about each and every one of you. But I am not managing your third-party contracts if you go with a private vendor. It is my job to manage the state-sponsored system, and I absolutely positively do that. We have contracts compliance things that we go through all the time with them. But I get a lot of requests from providers that'll be like, hey, I am working with Brian's EVV system, and it's not working on rounding, or it doesn't seem to know the difference between the hourly units and the 15-minute units in ICWP. What can you do about that? And I will tell you, I really can't do anything about that. I can get them in touch with our integrations people so they know the specs, but I don't manage each one of these 37, or I think we're up to 37 private companies to ensure that they're complying right and meeting your needs. Your option would be to pick, if you're unhappy with them, to pick another vendor or to use the free state-sponsored system, which you can switch to at any time. Okay, last thing, contacting the EVV call center. I encourage that your first stop when you have issues is to contact the call center. That's the number, 833-701-0012. That's the email website. They get about half calls, half emails on a daily basis. It's split. And then that's the chat. Nobody uses the chat. I don't know why y'all don't use the chat. I don't use the chat either, though. Like, I always have the chat box pop up, like with Delta and everything else, and I'm always like, nope, I'm not interested in chatting to you, and I don't believe you're a real person. I think you're a computer. But there is also a chat option that you can chat with actual live representative who mans that. It's not, whatever the thing was this morning, Gabby. It's actually a real person that will chat to you. When you do call the call center, it is really, really important that you have your agency name, your ID, either have an NPI or an EIN, just in case we need to really dig in, because some folks have 20, 30, 100 IDs, believe it or not. Have an email address and a callback number, just in case something happens so we can immediately call you back. Okay, if you have specific questions also, this is again, the support numbers, I'm just doing it twice, that are down here. There's also a Georgia Medicaid EVV mailbox, and you are welcome to email me as well. For those of you who doesn't know my email address? It's a lie. Y'all know my email address, because all y'all email me all the time. I get like 500 emails a day. So I don't believe that you don't know my email address. But if you don't, it's literally my first initial and my last name. So it's BDOWD. So B is for Brian, Dowd is my last name, DOWD, at DCH for Department of Community Health, .GA for Georgia, .gov for I work for the government, right? So it's bdowd at dch.ga.gov. Now, I promise you, my first question is going to be, did you contact the call center? And then if it's not a call center issue, my second thing is going to be like, have you contacted GAMUS? But if it's a question about like, hey, why does EVV function like this? If you've gone through the steps and you have complaints and you don't feel like your issue is being addressed, you should of course escalate it to me. We have a big, thick list of contract requirements that we go over quarterly with our vendors, and we impose damages when they aren't doing what they're supposed to do. So absolutely you should contact me about those larger issues, or if you're having real concerns and complaints that aren't something that can be addressed through the EVV system. Okay, I think that's the end of my slides. Let me check my time. I'm at 9:33, so we're doing good. I want to pause here for any questions, concerns, comments, complaints, general gripes.
What is the need for you to have an EVV under the state of Georgia compared with other vendors is coming to EVV? What is your liking this by, or any special reasons why you have to have an EVV system?
Thank you for the mic. So the question was, what is the reason why we have an EVV, and what's kind of the difference between the state-sponsored system and the other large list of provider agencies that you can use? And that's a great question. When we started in 2018, first of all, it's a mandate that we do EVV, and the penalties get worse and worse and worse for states. So even those states who initially said, hey, federal government, I'm not going to do your EVV thing, AKA Wyoming. Wyoming actually did that. Wyoming was like, we're never implementing EVV. Well, now it's year 4, and guess what Wyoming has started to do? Oh, this penalty's getting big. Guess what we're going to do? An RFP for EVV. Yeah, they were real tough until the penalty got to like a percentage point. And then they went, ooh, we don't have the state tax dollars to do this. We really need to implement EVV. So that's the real reason that states have to comply. But we think it also improves quality of service. It improves accountability. We've even had providers at this point who have been using the state-sponsored and other systems for a while actually tell us they like running through the EVV system because it does scheduling and a lot of billing for them, and it's easier for them. When we started the program, we decided we didn't want to be one of those states that made you use one system. It's not very Georgia, right? Georgia is much more about options and open markets and that sort of thing, and not kind of, hey, the state is going to mandate you use this. So we decided we would do an open model, and we would use any provider who could meet our requirements were able to come in. Now, it's your individual choice whether or not to use one of those third parties. And I've seen some very good third-party systems that integrate really well with us, and I've seen some that are on the struggle bus. They're having trouble with their folks over and over again. They're still integrated with us, but you need to make a business decision as kind of what's best for you there. But we want to give you the options. Any other questions? Yeah, there's a question in the back.
Hi, I have a question in reference to the call center. There's a couple of times that I've been on there for like an hour waiting. How can what's the best route as far as asking questions versus calling the call center? Would it be the EVV support? Or?
Yeah, I would say you shouldn't be on the, I mean, we track call center metrics. And we look at those instances where people are, because there are very strict contractual requirements. So to be honest with you, you've probably driven some liquidated damages for the vendor, because when we see those, we ask for our money back. So I guess thank you for being on the call for an hour. Mm-hmm.
Once a week on Tuesday, with Mr. Dale, he's awesome. I asked him questions.
Right. So let me say there's a couple of things there that are really great in that question that I'm going to just steal. First of all, there's a weekly webinar that is available for you all. And if you go to that, there's not that many people who go to it either. It's not like a huge amount of people. So you can get kind of some one-on-one instruction every single week. And that is with the NetSmart people. Looking for Lindsay to shake her head at me. So that's with the NetSmart people. So it's not the call center or the conduit people, and they have, like all call centers, they may have some turnover, they may have some issues with education, but those weekly webinars, you're getting the NetSmart people who really know the system, and they're pretty sharp. Yeah, Lindsay. Yes. Go ahead.
Okay, so to get to those webinars, I'm Lindsay Mack from NetSmart. Hello. To get to those webinars, you go through your training portal. That's through your provider dashboard that you're already accessing for billing. You click on training, go to training, and then there's an option to register for the session. Very simple. Dale is fabulous. Good call on Dale. We love him. So I absolutely recommend doing that. There's, 3 people on there is usually a crowded session, and it's a full hour, and he can absolutely help you one-to-one usually towards the end of that session. We're really pushing those because he's great. So thank you for that feedback. I'll let him know.
Yeah, and thank you for bringing that up, because I wish more people would utilize that. Here's what I would say to your other question. If you've been on the call center for an hour, if you have been on the call center and you specifically don't feel like the call was helpful or the person really was able to answer your question, I would either send that in to me or send it into the DCH EVV mailbox. and we can have that as part of this. So we have somebody in our unit. Her actual name is Linda Chapman. She's in my unit, and she's an attorney, and she monitors the call center. So what she will do is she literally pulls the call, and she goes and listens to the call, and then she gets with the call center supervisor, and they work out a corrective action plan, and it also it triggers like liquidated damages in the contract. Now, we will review the overall metrics of it for liquidated damages, but sometimes it's important you let us know that so we make sure we can meet your need about that call.
He might be my best friend because I don't have an issue with that. And then, like I said, I didn't get the answer that I was supposed to get from them. When I went onto the webinar, I went ahead and asked Dale, and he provided the actual.
No problem. Actually, that's something we need to know about. So you can always let us know of those things, and that goes for anyone here. Okay? Please do so. Do that. Yeah.
Okay, we have a couple of questions. We have a question online.
Okay.
Yes. Sherry is wanting to know, are the presentations being posted on DCH or GAMIS website?
It's posted on the GAMIS website. So, yeah, the presentation should already be there, right?
So all presentations for this workshop or Medicaid fair will be located on the GAMIS website, as well as all the monthly workshops under the provider information, provider notices. So each workshop will be labeled, and actually they're already out there.
Yeah, so you don't have to worry about like writing down things or anything else. We had a couple other questions. Let me start here, and then we'll go right up here, okay?
Hi, good morning.
Good morning.
Other than it being free,
Uh-huh.
what other advantage is it for us to use the state software? I mean, as changes are implemented, would that be the first thing that's changed, or would we just?
Yeah, that's a really good question. So I would say this. It's really a great question. For me, the advantage of using the state-sponsored system is you don't have a layer between you and the state-sponsored system, because your third-party system integrates with the state-sponsored system, right? So if you go to a third-party system, it may be great and you may be using it for its functionality, but it's still got to talk to our system. And like when we update for rate adjustments, we let the third parties know, hey, this rate has gone up, but I don't have any mechanism for yelling at Brian's EVV company and saying, hey, you got to get this rate updated now, right? Our providers are having to go in and manually adjust their rates, and that's too much work. So we're always kind of have our finger on the pulse of Conduit and NetSmart, but we don't for Brian's EVV or one of the other 37. Yeah.
To piggyback off of this nice lady's question, for the state sponsors site, does it house patient EMR documents as well as employee documents like credentials? If we were to come off a third-party site, which is what our company uses, to switch to the states?
No, the state doesn't pay for that. It's not that the system might not have it available, but the state only pays for the functionality that is associated with EVV. There was this gentleman up here had a question, and I focused on the back of the room, and now I feel bad. Yeah, it's the same. It's the same link that Lindsay. Are you a provider? Okay, so on your provider portal dashboard, there's a link for training, right? And there are a host of videos on that site as well. And they're broken up for people like me that have attention deficit issues. So they're not like 45 minutes in link. They're like 8 minutes on how you reset. I don't think how you reset your password is 8 minutes. I think it's like 4 minutes. But like they're broken out like claim submission, scheduling into little chunks so you don't get terribly bored. There's another question on the internet, so hold on one sec.
Yes. So, Delano Williams is wanting to know, are there any updates to minimizing manual
So for share, there's no updates. I would encourage that provider to send me an email, and I will have Marilyn Ellis reach out to them and walk them through shared services and CLS. Okay?
Okay, and I have one more.
Okay.
Well, I have a few more, but Anita H is asking, when is the 5% rate increase going to be updated in the EVV system? I have to manually update each claim to the new rate every time consuming, it's very time consuming, and they don't give the option to update per code.
All right, so I'm going to let Lindsay talk about this. So the rates are going to be updated today. Congratulations, Anita. You win the lottery. Leave that complaint at the door.
Okay?
I got
I'll do one more online one. Linda Chapman says, Brian, can monitor.
Linda's the person I talked to you about earlier, so she's in the internet sphere listening to what I said, and now she's probably going to tell me what I said wrong. Go ahead, Linda.
She says, Brian can monitor, but really, really need time of call, date of call, name of rep, if possible, can guesstimate.
Thank you for saying that, Linda, because Linda always tells me this, and then I always forget, and then she always emails me this. So if you do have a specific complaint about the call center, guys, try and give us the date and the time and the person you spoke with, if you can remember that at the call center, right? But at a minimum, we need to know the date and time. Because sometimes what Linda and I've sent Linda complaints from providers, and they have been like, well, I don't remember what day it was, and I don't remember what time it was. And we're like, ugh. Now there are 9 million calls we got to like kind of try, and we still try and sort through it. Linda does a great job of like sorting by providers and different agents' names to try and find it, but sometimes she just can't find it without at least like a date and time stamp.
Are call reference numbers provided by the call rep? Because I'm experiencing
Yeah.
Sometimes emails will be sent out to.
So if you have a call reference number, any documentation you have from them, please let us know about it, because it's really important for our compliance issues, okay? Because Linda literally pulls those calls and listens to them, okay?
Okay, I have one more.
One more, and then we'll get to the people in the room.
Yes, okay. Christy Toner says, we have had several claims that were billed through TELUS with EVV. The claims are showing denied in TELUS, but are being paid in GAMIS. Why would this happen?
I don't know why that are showing denied in EVV and not paid unless it was part of a mass adjustment. So we've been doing the mass adjustments through GAMIS to make sure folks get their retroactive payments. So it may be that issue, or it may be the fact that the claim was billed directly into GAMIS. But if you want to provide the ICNs to the call center or to Gainwell, we can research why there's a differential between the two and let you know. It's hard without having the ICN to really look and see what happened.
Brian, there was also an additional question on when is the weekly calls for EVV. Can you repeat that?
Thank you.
Thank you.
Tuesday at 11 a.m. I knew that off the top of my head. Yeah, Lindsay? So we're going to add an option for morning and the afternoon, which I also knew about. If you think I didn't, I did. And so that will be going into place very soon. So they'll put information out on the EVV notification about that.
I just have a question, maybe for you or Lindsay. I'm fairly a new provider, just got my number and everything. So I was just trying to figure out, where do I go to see? I'll do adult day health center. So I'm just trying to see, where do I go in my GAMIS portal to see like the rates for, you know, how do I build the rates, like level 1, level 2? Where can I find that information?
Okay, so here's a good thing for you. ADH is not part of EVV.
Okay.
Congratulations. But what you can, it's really just personal support services. But if you go to your ADH manual on the GAMIS website, there is an appendices that will have your code and rate tables for all the waiver services, okay? So that's just on mmis.georgia.gov. So that's, I mean, I'll be honest with you, I've been doing this way too long. I'm really old. I know I don't look like it. I know I look surprisingly young. But I know, I can't remember all the codes and rates.
Yeah.
I mean, I have people who work in my unit who know what every code is, and I'm like, oh, I'm sorry you know what all those codes and rates are off the top of your head. So I always have to go to the manual. Yeah. More questions?
I am seeking advice from you. You mentioned earlier the billing and PA allowance hours.
Uh-huh.
So I'm concerned about anybody who over 40 hours a week and then end up showing hypothetically 2 hours extra over. So how do we are only allowed to billing PA hours or unit.
Correct.
So how do you, am I allowed to making modification before that?
No. So let me explain how the waiver program works. That's another really great question. Y'all are doing good questions today. So the way we get to how many hours of services you are authorized is via medical necessity, right? It's not based on anything else. It's not based on members' wishes. It's not based on, hey, in order to keep a staff member, I need at least X number of hours. There's an assessment process that happens annually and when you enter the program. It looks at what your unmet needs are, and it authorizes hours according to that unmet need. That's what case management and our external review organization, Alliant, who's out there, reviews. If you have a member whose needs are not consistently being met by the authorization from the plan of care, you need to have a conversation with the case management company. And you need to say, hey, the hours that were authorized don't seem to meet this individual's need. Can we look at if the plan of care needs to be modified to add more hours? Or conversely, I know this is going to be blasphemy, but less hours, right? Because one of the things we're seeing at EVV is like sometimes people are getting huge authorizations, and these are Metro Atlanta people where there aren't a lack of providers, and they're not utilizing even half of those hours that are being authorized. So, and let me give you one other thing with that. If your member has had an incident, let's say they've fallen, let's say they've gone into the hospital, we need to be making sure as case managers and providers that their plan of care accurately reflects their need post-hospitalization. If I have fallen and I have a broke hip, my needs cannot possibly be the same as it was before I went into the hospital, right? And that needs to be reflected in the plan of care and number of units that we authorize.
As a home health provider, we really appreciate the reprieve for the extension.
You and me both.
But with that being said, will there be more focus on those that are using the system right now versus trying to help home health providers get on board? What is the suggestion for us as home health providers? Should we wait?
I would wait.
Wait.
I would wait until we provide more information. We will have a very long 6-month rollout of the system that goes through training options. It goes through a soft launch. And I don't want you to get on board now because honestly, it's the PSS world is different than the home health world because the PSS world is driven by prior authorization and home health doesn't have prior authorization. So there's going to be a little bit of a different workflow.
I have 2 questions.
Okay, and I'm going to say this is probably where we're going to end, y'all, because it's 9:54.
Okay. My first question is, because I know that we get updates with the EVV, but as far as ICD-10 codes, we've had multiple IDC-10 codes in EVV, and then my administrator came across a situation where she couldn't bill because there were too many. I don't know if that was because of updates or what the deal was, but do you know why that occurred?
So that's a good question, and I know you got another one. So unspecified ICD-10 codes are not allowed in Georgia. There's a very few limited number of unspecified ICD-10 codes that we do allow for, but it's only a handful. So things like unspecified dementia, no, we just don't use those for billing. So you need to have a specified code. We did go through a project recently with NetSmart where we matched up what was in GAMUS with exactly what was in the NetSmart system. So that may have been happening before to get those unspecified codes in, but if you have a list, a group of, and everything is unspecified, you really need to go back to case management and say, hey, we gotta have a specified code on here. Other question?
And then my last question was just basically, where do we find when there's updates to the system?
Lindsay, you all put out information on if there's any update in the system. I'll let Lindsay speak to this one too.
Yeah, so usually if there's a large, here, I'll do this. Hello. If there's a large update that's going to affect all providers, we do send out a message within the system to the admin portal, and you'll have that message come into that inbox. Some of the updates that we put through, Brian spoke to it earlier, you'll get a banner message regarding that if we do any major system changes, but it'll be one of those two things, either the provider portal, the admin messaging system, or the banner message.
If it's large enough, we'll also put out a banner message that's on your remittance advice. And I also usually talk about it in the town halls. I haven't done town halls in a couple of months just because we've kind of been in a rolling place and we're trying to wait for home health. But you guys know I did 14 months of town halls for implementation, at least twice a month. So we'll likely start doing those town hall meetings again as well. Okay, I want to thank everybody for being here and for your time. It's great to see people face to face again. It's really kind of nice. And who knew they did this much to the Gwinnett Convention Center, right? Did anybody else drive up to this place and go, what the? I did. I really had a moment where I was like, what is going on? But thank you for coming and enjoy the rest of the Medicaid fair.
Excuse me, one more thing. If you would please, if you don't mind filling out the evaluations, we will be collecting those at the door. Just give us some feedback about the presentation. Thank you.